Hey guys, we'll get started in just a few minutes. I'm just going to let a few more stragglers come in and then we'll get started. Looking forward to seeing all of you.
Same.
Hey everyone, I'm just going to give a few more minutes. I think we have a few more people trying to come through and then we'll get started. Today we are talking about endometriosis and its relationship to adenomyosis, which I think is a very intimate relationship and important to discuss. So again, I'm just going to give a few more minutes to see if we have a few stragglers join and then we'll get started. All right. Well, we have over 50 people joining us today, which is awesome. I'll keep admitting people in as they roll through, but I'm looking forward to spending the next hour with you guys. I'm Dr. Rachael Haverland with Endometriosis Center of Excellence. And, today we're going to talk about endometriosis and its relationship to adenomyosis and kind of how these two intimately, overlap and connect. So why your painful periods, fatigue, bloating may not just be endometriosis, and why that matters more than ever because it's important to distinguish the two, understand how they overlap, but also find treatment plans that really are going to give you your best outcome. And it's important to be able to understand the underlying diagnosis so that when you treat all of the underlying etiologies, hopefully you can get to a place with, better quality of life and improved pain. So millions of women are told they'd have just bad periods, but what if it's actually happening in your body is more than one condition? And what if that's the reason treatments haven't worked? So sometimes we get too focused on endometriosis and sometimes we get too focused on the uterine inflammation, but it's really important to be able to identify both and treat both. And sometimes there is a little bit of gray area in teasing these out to try to identify which etiology, which underlying condition is really causing most of your symptoms, but usually it's multifactorial. So this webinar uncovers the misunderstood connection between endometriosis and its lesser known twin, adenomyosis. So by the end of this webinar, you'll know the difference between adenomyosis and endometriosis and why recognizing both could change everything about your treatment plan. And that's one of the reasons why it's so important to have individualized treatment. Endometriosis treatment is not a one-size-fits-all. It's very important to listen to people's goals and understand their individualized symptoms so that we can formulate a plan to get the best outcome. And so hopefully by the end of this, you'll gain some more knowledge. So if you've been exhausted from endless bloating, painful periods, dismissed doctor's visits, and treatments that don't work, there may be something your provider has missed. And so that's why it's very important to advocate for yourself, but to really listen to your patients and understanding. So hopefully we can explain this all without complex jargon, just real research-backed answers that could finally validate everything that you've been feeling. So what if I told you that the pain, fatigue, and heavy bleeding that you've been living with might not just be endometriosis, and that there's another hidden condition that doctors often miss? Studies show that many women diagnosed with endometriosis also have adenomyosis, but they go years without knowing it. I'm Dr. Rachael Haverland at Endometriosis Center of Excellence. And I'm a board-certified gynecologist. I specialize in minimally invasive surgery, but specifically endometriosis excision. And my goal is to uncover the real reasons women like you suffer for years without answers, to listen to my patients, to understand their symptoms, and to formulate a plan, an individualized plan, so that you can get your best outcome. So if you stay to the end, I'll send you my endometriosis and adenomyosis symptoms checklist so that you know exactly what to bring up at your next visit. I am adding a few more people coming in, but again, I'm Dr. Rachael Haverland with Endometriosis Center of Excellence. For this next hour, we're going to be talking about endometriosis and the intimate connection with adenomyosis. I want this to be interactive. So I'm kind of talking to myself for the next hour, but I'd like you to use the chat on the side and interact. I would love to be able to get to know you and see where you're from and answer questions that you have. But when we interact with these webinars, I feel like we get a lot more out of it. And hopefully I can answer at least a few individualized questions and get to know you, more. Let's see. All right, so we're getting started. Can we get a replay? I think that this is being recorded, and so some of this may be put up on YouTube at the end. And so hopefully you'll be able to watch this afterwards and get a little bit more information. Oh yeah, so all right, so we're going to get started about, with talking about the endometriosis and the adenomyosis and this intimate connection. Later in the chat, I will post a link in the chat where you can schedule a visit with my with my operator. Her name is Cyrus. She's excellent. And during this phone call with her, you can talk to her about scheduling a visit. She'll go through over your insurance information and she'll help get you scheduled. But you can do that through this link that I'll put in the chat a little bit later. You can also call the office or submit a form online. We're also happy to reach out to you that way. But the easiest way, at least in the webinar, is probably to click on the link and then schedule this phone call so that you can get a visit scheduled. All right, so we're gonna talk a little bit about endometriosis and adenomyosis and what is the real difference. So there is a misconception. If I have painful periods, it must be endometriosis. Well, frequently it is endometriosis, but sometimes there are aspects of symptoms that do not correlate to endometriosis and that give us signs or reasons to think that there may be other etiologies also contributing, to your symptoms. So breaking down the locations of how of the tissue, like where the endometriosis grows. Endometriosis technically grows outside of the uterus. Adenomyosis grows into the muscular wall. So we don't know everything about endometriosis and adenomyosis, but we think the most prevailing theory for endometriosis is that these cells implant outside of the uterus. So they are there even when your body is formed, when you're in in utero, and as your body grows, these cells grow with estrogen, and so estrogen kind of stimulates these cells to grow and continue to grow. So many women with endometriosis have painful periods from the very beginning, and this is stimulated by estrogen and their cycles. Um, but adenomyosis is different. It actually is in the uterus. So we talk about this frequently, that hysterectomy does not treat endometriosis, which is absolutely true. However, adenomyosis is an inflammation of the uterus itself. The lining of the uterus grows into the muscle wall. Women with adenomyosis have slightly different symptoms than women with endometriosis. So, a uterus, when we see this at time of surgery that has adenomyosis, is very soft. It's very boggy. It's edematous. So, the uterus should be hard like the back of your hand, but when it has adenomyosis, frequently it's edematous. I can push in with my instruments, and it takes a while for it to pop out, kind of like a sponge. It's very soft. Sometimes you also see the discoloration, so we call it mottled, but there's light areas of lighter coloring on the uterus or areas of darker coloring. Also, it can look not perfectly smooth because of this fluid accumulation in the uterus. The uterine wall can be kind of have ripples in it, or you can see a little bit more of that sponge-like appearance, which is consistent with adenomyosis. So one of my patients had a hysterectomy for endometriosis, but the pain never stopped. Turns out that the hysterectomy treated the adenomyosis, but it did not treat the endometriosis. And that's very, very important. Some people wonder why I had a hysterectomy and my symptoms did not resolve. And that's because the definition of endometriosis is that these cells are not in the uterus. They are outside of the uterus. They're implanted outside of the uterus. So the most important part or aspect of surgery is to excise and to remove the endometriosis cells, so that there's a better chance they don't recur, better chance they don't continue to cause your nerve pain and damage the cells. And so when we do just a hysterectomy, yes, that is a way to treat the adenomyosis, but it is not treating the endometriosis. And so it's imperative to make sure that you are excising and removing all of the endometriosis before doing the hysterectomy. The hysterectomy is actually very, very straightforward. It's relatively easy, but the endometriosis excision is what is removing those cells. So if you don't treat both at the same time, a hysterectomy alone frequently or will not treat your endometriosis. So, one of the most important messages here is that you can't treat what you don't diagnose. And these two conditions require very different strategies. Here at Endometriosis Center of Excellence, we do try to use a multidisciplinary approach, try to treat this endometriosis holistically. Endometriosis is very much a whole body disease. It affects your body as a whole with chronic inflammation. The most common side effect or symptom of endometriosis is fatigue, because it's working and beating down your body in many different ways and in many different avenues. And so treating the body as a whole, trying to anticipate the endometriosis, treat the inflammation, and then ultimately surgically treat the underlying etiology by removing the cells. But some of that includes diet, exercise, acupuncture, pelvic floor physical therapy, I think is paramount to long-term treatment and outcomes. We do talk about, physiatry, nerve injections to try to help with some of the nerve pain. There is chronic damage to nerves that can be caused by endometriosis, so trying to let those nerves rejuvenate and heal. We do talk about, hormones, and we'll talk about hormones a little bit more down the road and how they relate to adenomyosis and endometriosis. Birth control and other hormones are not for everyone, of course. Some people don't tolerate birth control well. Some people just don't want to take it, and that's perfectly fine. Understanding the risks and benefits of everything we do in our lives. Some women do see a large benefit from taking hormones for the adenomyosis, and many other people don't. But that's why individualized treatment is so important, and why it is so important to talk to patients, understand their history, what they've tried, what they haven't tried, some of the side effects of medications, and really what their goals are going forward. And so I want to talk just a little bit more about adenomyosis. So at least 30% of women with endometriosis also have adenomyosis. So adenomyosis it depends on which part of the country you're in. Some people say adenomyosis, some people say adenomyosis. I say adenomyosis because I'm from the South, but if you talk to people in the Northeast, they may say it a little different. But essentially, it's a disease of the uterus. You get inflammation of the uterus. And so sometimes women with endometriosis, a hysterectomy is a reasonable approach. However, this is treating the adenomyosis, not the endometriosis. Leaving the uterus in does not increase your risk of endometriosis recurrence. We have no evidence of that. And so many women do not need a hysterectomy in order to treat their symptoms, but especially if they don't have high suspicion for adenomyosis, a hysterectomy is not necessary. And so adenomyosis is where the lining of the uterus grows into the muscle wall, where the uterus gets very heavy, boggy. Symptoms of adenomyosis do overlap with endometriosis, but there's a few specific things that we look for. So women with adenomyosis tend to have excruciating pain on their cycle, which also can be endometriosis, bloating, pain that feels like a bowling ball, like pressure, heaviness in the pelvis, pain that radiates to their back and down their legs. That is kind of classic adenomyosis. So these symptoms of adenomyosis, these are the most common symptoms. Not everybody has these, but usually you also have very heavy bleeding and prolonged bleeding. So bleeding more than 6 days, passing clots, soaking pads. Endometriosis, while it causes a ton of damage, it causes inflammation, it affects your nerves, it affects your muscles. One thing that endometriosis does not do is affect the amount of bleeding that you're having. That is more related to the hormones or the uterus itself, and certainly can be related to adenomyosis. Sometimes fibroids can also cause these symptoms, but really it's important to tease these out and to really evaluate their symptoms to try to understand best what are next steps. But endometriosis alone does not cause heavy bleeding. That is more of a hormonal effect or adenomyosis affecting this, and again could be also fibroids. But it's very important to understand the underlying etiology of endometriosis and adenomyosis, how they are similar, but how the symptoms can be very different. All right, so why hysterectomy doesn't always work and when it might. So there's a misconception that removing my uterus will cure everything. I can't tell you how many women come into my office and like, well, I had a hysterectomy. They told me this, they would fix it, but I'm still in pain. It actually made no difference. I don't have bleeding, but I still have pain. And so why hysterectomy may stop adenomyosis pain, but it won't treat endometriosis outside of the uterus unless it's truly excised. And I think this is a very, very important component to talk about. And I try to beat this home. Hysterectomy does not treat endometriosis. However, it is a good treatment plan for adenomyosis, but it's almost always when you have adenomyosis, you also have endometriosis. So I think I mentioned earlier, at least 30% of women with endometriosis also have adenomyosis. However, on the flip side, if you have adenomyosis, it is like 80 to 90% chance that you have endometriosis. So if we can see adenomyosis on the imaging, if you have symptoms of adenomyosis, the likelihood that you have endometriosis is incredibly high. And so it's important when you're counseling a patient, when you're talking to them, to talk to them about what you could find, and what you may have to leave behind. Understand your limitations. I am an endometriosis surgeon. I remove endometriosis from the colon, from the bladder, from your nerves, from your uterosacral ligaments, from your girders. I feel very comfortable removing this from difficult locations, the diaphragm, the small intestine, the large intestine. However, it is important to understand if you're going in for surgery for a hysterectomy, what they're going to do with the endometriosis if they see it. Are they going to leave it behind? Are they going to plan to burn it? If you burn the surface, most of the time the endometriosis comes back, and so it's not a good treatment plan. But really talking to your doctor about what they anticipate finding during surgery and what they're going to do when they get into surgery with what they find. All right, so I'm going to go over to the chat a little bit and answer A few questions. So thank you guys for utilizing the chat feature so I don't have to just talk to myself the whole time. I love talking about endometriosis. I'm very passionate about it. I feel like this is my calling. And we've helped a lot of women at the Endometriosis Center of Excellence. We've helped over 100 women since we've opened, probably well over that. We've been open for 8 months. Yeah, so almost 200 women have had treatment with Endometriosis Center of Excellence at this point, and really seeing that change, especially in this DFW area. But maybe half of my patients are from out of state or out of town, and it is just incredible to be able to see the advocacy for endometriosis. And a lot of it is patients talking to each other, helping each other out, rather through social media or just in the workplace, talking about where they were able to get treatment and where they were able to find relief. And it's just amazing. So kudos to you guys for helping spread the word and advocating for endometriosis and trying to find good, high quality and evidence-based care. All right, so this person says her gynecologist didn't seem to know the term for adenomyosis even after I was diagnosed. And unfortunately, that happens. Medicine is changing. We're learning more and more, but especially when it comes to women's health, sometimes we're behind on the on the research and finding high quality studies. But if you don't stay up to date on treatment plans and new studies coming out, a lot of times you will miss this. Some of the older doctors, especially, may not have to do this continuity of education. Or we're not taught about it in residency, but adenomyosis is actually very, very common. So endometriosis is 1 in 10 women. Adenomyosis is probably 1 in 15. And so it certainly can affect women's health, and it's imperative to be able to talk about it and understand the differences. And it's you have to, one, be able to diagnose it and then be able to talk about the treatment options, because hysterectomy is not the only treatment option for adenomyosis. And it's important to understand that and be able to kind of have an individualized plan. So we talk about yeah. So other people are saying as they're looking through, they're like, man, I do have, symptoms of adenomyosis. Remember, adenomyosis is painful periods similar to endometriosis, but it's heavy bleeding, soaking pads, passing clots, soaking through your clothes, anything that where you have to use both a pad and a tampon. So, changing out your pad or tampon, every hour or so, that is extreme, and that is not normal. That can lead to anemia, affect your other organ systems, but it also is a higher suspicion for adenomyosis. Again, other things can also cause heavy bleeding, but it's really important to at least to keep that in your differential. Okay, so I have one patient that is talking about how adenomyosis affects fertility. And this is an important one. So the most common cause of unexplained infertility is endometriosis. So if you don't look for endometriosis, it's still unexplained. You don't know. And that's why I do think it's becoming more prevalent and more fertility doctors are talking about endometriosis, because they're understanding how endometriosis affects fertility in so many different ways. Endometriosis, these are again cells outside of the uterus that implant in the body and cause inflammation. So endometriosis can affect egg quality. It also can affect your AMH. It can affect the fallopian tube, so it can make it harder for the egg and the sperm to fertilize in the tube and then also implant. So that is how endometriosis can affect fertility. And it is related to stage. So the higher stage of endometriosis you have, the more it affects fertility. However, the stage of endo does not correlate to pain. And so pain and endometriosis, there's not a direct correlation. You can have stage 1 endometriosis and debilitating pain, or you can have stage 4 endometriosis and have very mild symptoms. But this stage does correlate to how negatively it affects your fertility. Adenomyosis, again, is that inflammation of the uterus. So it's not necessarily affecting alone. If it was just adenomyosis alone, it is not affecting your egg quality or the ability of the sperm and the egg to fertilize, but it can affect implantation. And the reason is because there may be some inflammatory processes in the uterus affecting that implantation. Pregnancy is actually a very delicate and intricate process. There are millions of steps that have to go perfectly in order for a pregnancy to stick and be successful. The good news about both endometriosis and adenomyosis is once you get out of that first trimester, once you get out of the first few weeks where the placenta starts to take over and make its own progesterone, you're no longer considered a high-risk pregnancy. So throughout the rest of your pregnancy, at least if only related to endometriosis and adenomyosis, you're no longer considered high risk. So once the pregnancy implants and the progesterone starts being created from the placenta, you're no longer high risk for the rest of pregnancy. So the hard part is getting pregnant with endometriosis and adenomyosis, but once you're able to stay pregnant past the first few weeks, you're no longer considered high risk. This patient asks, is there ever any way to decrease your stage of endometriosis? So if you're diagnosed with stage 4 endometriosis, can you ever go down to stage 1 or stage 2? Unfortunately, at least in the medical community, if you're diagnosed at stage 4, you never go down. We always consider you stage 4. And same thing if stage 2 or stage 3, you're always at the highest stage that you have been identified at. And the reason we do this is because we understand the long-term sequelae associated with each stage of diagnosis. So higher stage of endometriosis, like a stage 4, for example, you have higher risk of it affecting your ureters, which are the tubes from the kidney to the bladder, or affecting the kidneys, higher risk of recurrence, more difficulty with pregnancy. You also understand the negative effects on the nerves because this endometriosis tissue has grown into the normal tissue and destroyed, some of the layers by that deep infiltrating disease affecting the nerves, affecting the bowel. And so technically your stage of endometriosis never decreases. It can only increase if the next time you have a procedure or if you see it on imaging and it's more advanced. Unfortunately, you can increase your stage. All right. So let's talk about a little bit more about hormones, or let's talk about treatment options for adenomyosis. I think that that's really important. So endometriosis, we talk about this multidisciplinary approach, treating the inflammation. And that this is also true for adenomyosis because it is an inflammatory response. However, it is confined to the uterus. But we still treat it with decreasing the inflammation first. So change in diet with clean eating, a whole foods diet, acupuncture, pelvic floor physical therapy can help because the uterus is heavy, affecting the muscles and the nerves around the pelvic floor. We talk about potentially using physiatry for nerve injections, but the gold standard for treatment of adenomyosis is progesterones or hysterectomy. And again, this should be very, very individualized because this is not a one size fits all. I have many women who have tried progesterones, birth control pills, IUDs, and they're not seeing the benefit. However, sometimes once we go in and remove the endometriosis by excision and clean out all of the endometriosis, then the uterus starts to respond better to progesterones. Most of the patients I see are fertility sparing. They want to preserve their uterus. They want to preserve their organs. Even if they don't want to have children, they want to keep their structures in their body where they started, and they don't feel comfortable with a hysterectomy. And to be completely honest, I understand. It's a big decision. A hysterectomy is not, complete, it's not benign. I do this a lot and I have really good outcomes. But only you know what is best, for your body. And I think that that's really important to sit here and talk to me about the pros and the cons of each procedure and what feels best for you. So while endometriosis can make its own estrogen, it has some aromatase properties that can convert other hormones into estrogen. So technically, even if you're not taking any hormones or you have your ovaries removed, the endometriosis can use this aromatase property to convert other hormones into estrogen. And so that's why they can continue to grow even after removal of the ovaries and even when on these big gun medications that may put you into menopause, like Orlissa, Lupron, Myfembree, the endometriosis can still progress because endometriosis doesn't follow the rules as far as um, theoretically how it should respond to progesterones. However, the uterus usually does respond really well. Adenomyosis responds very well to progesterones. And in doing so, these adenomyosis cells decrease the growth of the lining of the uterus so you have less bleeding. The uterus tends to decrease in some of the inflammatory process because that fluid that's being expelled decreases, so it may be a little bit less inflamed. And so many women with adenomyosis do see a benefit from progesterones. However, sometimes they don't see a benefit until the endometriosis has been excised. Um, Other women are trying for pregnancy, and so they don't really have this option of using continuous progesterone. So some people just use progesterone in their luteal phase, which is the phase from ovulation until your period. This doesn't work as well for controlling the symptoms, but it's still an option to try to give you some benefit while you're actively trying for pregnancy. And again, this is very much of an individualized approach because there are, progesterone is not completely benign. And, it may increase your risk of breast cancer. There's some fatigue associated with it. Some people notice weight gain. But on the flip side, it also may improve some of your symptoms from the adenomyosis, especially if in lieu of a hysterectomy or if you feel like that's not the right option for you. Some people also have some mood changes, feel like it decreases their libido. And so again, nothing is benign. Nothing we put in our body is completely benign. And so it's really important to understand the pros and the cons of each medication to figure out what is best for you. Now, another question is, does a hysterectomy completely treat the adenomyosis? This is true. Hysterectomy is a disease of the uterus. There are not adenomyosis cells that come out of the uterus. So the hysterectomy does fully treat the adenomyosis. There is no risk of adenomyosis recurring after a hysterectomy. Now, with that being said, most of the time they also have endometriosis, so there is a risk of endometriosis recurring, but the adenomyosis is fully treated with a gold standard of a hysterectomy. And again, this is very individualized. When I talk about a hysterectomy, I'm talking about removing the uterus. That is the definition of hysterectomy. With adenomyosis, I strongly recommend removing the cervix because you can have adenomyosis cells in the cervix. So if we leave the cervix behind, you may continue to have symptoms. I'm not discussing removing the ovaries. I think the ovaries are very important. And so most of the time, 99% of the time, I recommend keeping the ovaries. The ovaries give you all of your hormones. They give you the benefit of protecting your bones. They protect your heart. There's some cognitive protection, with the ovaries. And so there's also longevity benefits of the ovaries. So trying to keep the ovaries for as long as we can. And keep them healthy by removing the endometriosis around them so that they're not living in this inflammatory environment. But so like I mentioned, hysterectomy is removing the uterus. Usually with adenomyosis, I do recommend removing the cervix. And frequently we recommend removing the fallopian tubes. We think some ovarian cancer actually starts in the fallopian tube. So by removing the fallopian tubes, it does decrease your risk of ovarian cancer to some degree, which is quite beneficial. But, again, this is an individualized approach depending on what your symptoms are and depending on your goals. If you a hysterectomy is not the only choice. There are other medications that can help and lifestyle changes that may give you benefit enough to where it's not affecting your quality of life negatively. And every person is different. And I think it's really important to listen to them and understand and not just give this algorithm of next steps because it doesn't work for everybody. And it's very important to understand the differences between endometriosis, adenomyosis, and the treatment options. All right, so I'm going to go back through some more on the chat. So thank you guys for putting that up. Also in the chat at 12:24, we do have a link. You can click on that link and make a meeting time. At that meeting time, you will talk to Cyrus. Cyrus answers on my phone. She's excellent, and she'll be able to walk you through scheduling. She'll be able to go over your insurance, show you what scheduling looks like. And so you can make that meeting with her and schedule an appointment with me after you meet with her. So it's there in the chat if you'd like to use that. You can also call our office or use the the online form to get a hold of us. Um, so let's talk about endometriosis and how it affects kind of the nerves and some of the body long term. So endometriosis is causing this chronic inflammation. Your body has, again, it's very much of a whole body disease. It can affect your nerves, it can affect your muscles, it can affect your immune system, but it affects your body, completely. And so it's important to treat this endometriosis from a multidisciplinary approach: diet, exercise, physical therapy, nerve injections. It takes a long time for those tissues to remodel. And then, at some point, if you've tried the less invasive measures and you're still not seeing benefit, there is a place for hormones. Again, this is very much individualized, but progesterone onlys, sometimes there's a benefit even to endometriosis. Theoretically, endometriosis, of course, can break through. I usually do not use the bigger, more aggressive medications like Myfembree or Alyssa because of the side effect profile. But I do have patients that come in, on them from other providers, and usually, or sometimes they see a benefit. Sometimes they didn't last very long because of the side effects. And these medications can only be used for a very short time. The Alyssa, Myfembree, Lupron. However, progesterone is able to be used long term. If you don't see a benefit after, I have a patient that said, I had excision surgery for endometriosis, and I'm still having really debilitating, periods and pelvic pain. And unfortunately, that can happen. Some of it's related to the chronic, damage that endometriosis has done to the nerves and the muscles. Some of this may be related to inflammation of the uterus itself. And so usually at that point, we recommend starting progesterones or trying to work with progesterones to see if your body tolerates it. This can be the form of oral progesterone, like as a pill form. IUD is actually a localized progesterone, so it's going to give you a little bit less systemic hormones. Again, many people don't feel comfortable with a foreign body with the IUD. Other people don't want to take oral medication, and that's okay. It's just it's important to be able to understand your options so that you can figure out what's best for you. And then ultimately, if progesterones aren't helping, a hysterectomy is the next best step once you feel ready. And some people never feel ready, and that's completely okay. It's very important to know your goals and know your body. You know your body better than I do. I've been doing endometriosis treatment now for over, 10 years, but this is not, even though I know the science, you know your body. So trust your instincts when it comes to treatment and treatment plans as to, what you want to do for next steps. Because some medications work, for some people, but it doesn't mean that it's absolutely going to work for you. And so it's really important to understand that. Okay, let's see. I'm going to go. Um, some of these patients are talking about how they are having such heavy bleeding. And briefly, before I talk about some of the um, more of the endometriosis adenomyosis connections, is I want to talk about how adenomyosis can negatively affect your body, not just your pain, but how it can affect you as a whole. So women with adenomyosis tend to have very heavy bleeding, passing clots, soaking pads. Risk factors of adenomyosis is time. So some women have had heavy bleeding from the very beginning. So they've always had this component of adenomyosis, but many women also see it worsen with time. Like the beginning, when they were younger in their teens, their period wasn't as heavy, but as they progress in their 20s, 30s, even into their 40s, the period gets significantly more heavy. Clots, anything larger than a golf ball is definitely not normal. Soaking pads. And if you get to the point where the bleeding is heavy, you can become anemic, and that can cause you can have iron deficiency. It can significantly affect your fatigue, but even more than just pain, this also can affect your other organ systems. It's important, to make sure you have adequate blood supply and oxygen to your other organs, like your liver, your kidneys, your brain, your heart. And when you become anemic and iron deficient, you can see the difference in some of the ways these organs function. Some women even have to get blood transfusions related to, their heavy bleeding. And so it's really important to try to identify the underlying etiology of the bleeding. Fibroids can also cause something very similar. Even cancer, can cause heavy bleeding. And so it is really important if you have bleeding to this degree, to be evaluated. Um, Similar to endometriosis, sometimes we cannot see adenomyosis on imaging, which is also frustrating. Um, However, when it's more advanced, or if the ultrasonographer or the radiologist have a higher suspicion, sometimes they're able to see adenomyosis on imaging. So if I have a patient that comes in and we talk about, the risks of possibly having endometriosis and adenomyosis, and they're having a hard time deciding what their next steps are, I usually get an MRI, and sometimes we're able to see that adenomyosis on the MRI. And what we're looking for in the MRI, they measure what they call a junctional zone, which is like the thickness of the uterine muscle, also the heterogeneity of the muscle. So typically the uterus is very homogeneous, meaning it looks the same throughout. However, when the uterus has adenomyosis, there's little lakes of fluid and these little pockets of fluid, and you see this edematous nature and why the tissue looks different. At least in the medical literature, there's a cutoff for the junctional zone, but I I found that to be inaccurate, unfortunately, on many different occasions. And so more I go through borderline junctional zone of 8 to 10 or above, and your symptoms. I mean, just believe your patients and understand what they're telling you is affecting their quality of life negatively. And I'm always so honored that my patients trust me to tell me these very intimate details about their life, how, they're bleeding through their clothes, or they're unable to be intimate with their partner because they're bleeding, or they bleed through their clothes at work, or their pain is so bad at work they're unable to function, or, they had to leave their graduation, or they had to leave their, daughter's birthday party because their pain was so severe. And these are very intimate life details. And endometriosis and adenomyosis are very real. Unfortunately, it can be a debilitating disease if not treated. And so it's imperative to find doctors that understand the diseases, that can help delineate the differences between endometriosis and adenomyosis if you have one or both, and find a treatment plan. And sometimes this is a marathon, not a sprint, using physical therapy, using medications, using, nerve injections, diet changes, exercise, trying to treat your body as a whole. Endometriosis can cause, damage to your nerves and your muscles, and sometimes it's very difficult to reverse some of that damage. Sometimes we're missing something. Sometimes there is an adenomyosis component that maybe we didn't identify before, but it's imperative to have a high suspicion for these so that we can make the best treatment plan. Um, and then, all right, so we're going to go back kind of to endometriosis and adenomyosis. What do you do if you have both or you don't know it? So there's a misconception. Wouldn't my doctor have told me if I had this? As reading through the chat, there's a few doctors that don't understand the differences, or aren't very experienced with the adenomyosis, mostly endometriosis. And while they're treated similarly, they're very different disease because they're affecting different organ systems. These cells are different. While endometriosis does not always respond to progesterones or hormones, the uterus classically does. And so there's certainly a benefit there of the adenomyosis and the progesterone component. And even if you've tried other birth control or progesterones or other hormone options that haven't worked for you in the past, sometimes once we remove your endometriosis and then we only have left to treat the adenomyosis, then you start to see the benefit from some of these hormone modalities, rather a progesterone IUD or an oral progesterone. And those sometimes are better tolerated than the classical birth control pills. So many OBGYNs miss adenomyosis on ultrasounds or confuse symptoms with fibroids or hormonal changes. So sometimes you can see a fibroid on an ultrasound, but it can also be what they call an adenoma, which is an adenomyosis that is spherical. But typically these adenomas are very soft and spongy, whereas a fibroid is very hard. But it is important, with the adenomyosis to evaluate. And most of my patients had some sort of imaging, at least in the last year or two, with the ultrasounds or an MRI, to evaluate the uterus to see if there's fibroids or adenomyosis. But again, adenomyosis can be difficult to see on imaging, especially if you have a low suspicion. MRIs are the best way to evaluate soft tissues, which is the uterus, but again, is also not perfect. So a lot of times we just go based on symptoms, and it's imperative to ask the right questions and understand the different symptoms between endometriosis and adenomyosis, how they may overlap, but also the intimacy between them, because at least 30% of women with endometriosis also have adenomyosis. And like I mentioned before, women with adenomyosis 80% of the time have endometriosis. And so understanding these correlations so that you have a high suspicion so that you can get the treatment plan that works best and a treatment plan that the patient feels comfortable with. Because many women don't feel comfortable with a hysterectomy, or many women don't feel comfortable being on hormones for the rest of their life. And it's important to understand that it's not a one size fits all, and everybody responds differently to treatment plans, and an individualized treatment plan, regarding one, diagnosis of the symptoms, and then two, deciding what next best steps are, is imperative to best outcomes. So, um, I have a patient that I saw, I guess about 2 weeks ago, and she brought her symptom checklist to her doctor, and she got a referral to me. And when she came in, she was going through some of her symptoms. She was talking about bloating, just extreme bloating to where she felt like she was pregnant, from one day to the next. The bloating was extreme. She kind of had this heaviness in her pelvis, pain, yes, that radiated to her back and down her legs, especially during her cycle. And, she had been on and off of hormones, but she really didn't tolerate them very well. She was having mood changes, and it was affecting her mental health. And so she wasn't able to tolerate those very well. She is a woman that decided she didn't want children. I always ask patients, because some of my patients are fertility patients, and that is their main goal. But women are much more than just baby makers. And I have a lot of women that by choice decide that they don't want to have children, or the endometriosis has affected them to the point where they don't feel like they could raise a child because their health is so deteriorated. But my goal is to understand, the symptoms, and then give you your treatment options so that you can make the best decision for yourself. This patient that came in, we talked about the correlation of endometriosis and the adenomyosis, and she actually had surgery with me just the other day. And honestly, she wishes she would have done it sooner. And sometimes it's hard to decide, and it's not an easy decision. But she did decide to have the hysterectomy. She kept her ovaries, so the ovaries are still giving her the hormonal benefits. She'll go through natural menopause around the same time she would have earlier. But she feels that inflammation lifted. We did find endometriosis at the time of her surgery as well, which I would have anticipated. Endometriosis and adenomyosis frequently go together. But we were able to excise the endometriosis and remove the uterus. Pathology came back and did confirm adenomyosis, but ultimately, I tell patients it doesn't matter what pathology shows. It just matters how your symptoms improve and your symptoms resolve. And that's the ultimate goal of getting your quality of life back, getting you to be able to enjoy the time that you have with your family, with work, social activities, exercise, just giving you a fresh start. So, when you know the signs and you speak the language, understanding endometriosis and adenomyosis, you can finally get the care that you deserve. And I hope that, this webinar, you've been able to learn a little bit about endometriosis and adenomyosis, the differences, kind of how it affects your body differently, but also the strong correlation between the two. Remembering that hysterectomy does not treat endometriosis, but also if you only have a hysterectomy and we don't excise and remove the endometriosis will still be there. You'll still have symptoms of endometriosis. And so it's imperative to understand the differences, but also to advocate for yourself in treatment plans, because many doctors don't feel safe or comfortable doing endometriosis excision, removing endometriosis from the colon or the bowel or the ureters or the nerves. And so you want to be sure that if you go in for surgery, that your doctor is equipped with all the tools to remove endometriosis and handle anything that they find. All right, so we're going to go back over to the chat before we finish up. It's been great. Thank you guys for hanging with me for this last hour. I'm very passionate about endometriosis and just advocating for women with these diseases. Endometriosis a very common disease. It affects 1 in 10 women, and unfortunately is dramatically underdiagnosed. And frequently related to this endometriosis is the adenomyosis, and it is so important to try to delineate the differences so that we can find a good treatment plan. And it's not perfect, but you have to have a high suspicion for it based on symptoms so that you can give, the best evidence-based care. And adenomyosis sometimes is also very difficult to delineate because the symptoms can overlap with endometriosis. But if you have the knowledge to try to tease out and to understand this, we can get a good start as far as treatment planning and decreasing that overall inflammation in the body, decreasing your pain, so that we can sort of attack it from all sides to get our best outcome. Um, all right, let's see. Here's a good question. Where in DFW area is ECE located? Um, there we go. I was able to search while we listen in Plano. So I do have an office in Plano. Um, I have clinic there on Tuesdays. I also do telehealths. We are planning to move our office back closer to Central Dallas, starting at the beginning of the year. So we're working on that to kind of have a more permanent location. But I have women that have telehealths for me from all over the state, even discussions with people from outside of the state. About half of my patients are outside of the DFW area and come in for surgery and different treatment plans. And I'm very honored, that the women trust me with their health and their stories. And it's very rewarding. And it's fun. I tell patients, on surgery day, I'm just as excited as you are to go in and see where the endometriosis is, to remove it, to search through every organ system, to try to excise and remove all the endometriosis. And almost most, if not all of the time, we're able to remove every visible disease of endometriosis. And although it can recur, by excising and removing the endometriosis, we do get our best outcomes. Um, All right. So adenomyosis, we talked about how it can cause organ damage, related to the really heavy bleeding. So it depends on how much bleeding you're having related to your anemia and your iron deficiency as to if it's actually dangerous to your body um, outside of anemia and pain. But I will say leaving that, that chronic inflammatory entity in your body likely has more long-term sequela than we even know. Because when your body has chronic inflammation, you're higher risk of cancers, but also just your body deteriorating. And so even though it's not perfectly clear cut, just based on the evidence that we do have, these chronic inflammatory diseases likely are affecting our long-term sequela, like long-term longevity of our lives. This patient says, if you think somebody has endometriosis, would you recommend excision to improve fertility? That's absolutely true. Excision surgery with removing the endometriosis ultimately is improving the inflammation in the pelvis. Therefore, optimizing the ovaries, giving you better egg quality, makes it easier for the egg and the sperm to fertilize in the uterus and then implant. So excising the endometriosis has shown benefit for 6 to 9 months after surgery. Now, ablating or burning the endo hasn't shown any benefit, but that's because the disease isn't being removed. So the environment around the pelvis ultimately will not change. But if we excise the endometriosis, that does give you a benefit. Fertility is really hard because it's not, perfectly black and white. Some people, do egg or embryo retrievals, before surgery. Some do it after surgery. It's very, again, individualized, depends on if you have endometriomas, the size of the endometriomas. It's a discussion with me and your fertility doctor, and we work very closely hand in hand to make sure that we're giving you the best outcome. But everybody, again, is individualized. Um, all right, so let's see. This one says, I've had a laser ablation. Can you still have adenomyosis and endometriosis? So women with adenomyosis should not get an endometrial ablation. That's burning the inside of the uterus. That's not ablation surgery where you burn the endometriosis implants. This is actually burning the inside, uterine ablation. Women should not get that with adenomyosis because they have a much higher risk of continuing to have pain and what they call post-ablation syndrome. And so frequently we avoid that. Somebody asked if fibroids can grow after hysterectomy. No. So fibroids and adenomyosis are completely treated, with the hysterectomy. So, um, just kind of circling back, with endometriosis and adenomyosis, I hope now that you understand why your pain might be more complicated than just endometriosis, understanding this adenomyosis aspect. And not everybody has this, of course, but it's really important to understand that this may be a component, finding all of the etiology. So if you treat you as a whole, as a holistic entity with a multidisciplinary approach, that's when you're going to have your best outcome. But knowing the difference and figuring out what's actually going on in your body can feel overwhelming. So can I take just a few minutes to show you how to get clarity and create a plan tailored, to your symptoms? So if you come see me, you do get a full consultation. Literally, we sit here for 30 minutes and we talk about your symptoms. We go through the different organ systems. We go over your history. We see what you've tried in the past, and we formulate a plan because, again, everybody's goals are different. Everyone's symptoms are different. So it's imperative to make sure that we're really treating you as a whole and getting to your goals. Again, a lot of times this is a marathon, not a sprint. Some of my patients come in for, fertility is their goal. Other one is pelvic pain. Sometimes it's both. But luckily we have treatment options and treatment plans, for that. So click on the link to schedule with me. So that link again will get you to Cyrus. She answers my phone and she'll be able to talk to you about surgery scheduling. She'll go over your insurance and get you on the books. Right now we're booked out. Probably 8 to 10 weeks, for clinic visits. But she can help you get on the schedule. You can also call the office. But first we do a symptom and history deep dive. We go over your full experience and match it both against the endometriosis and the adenomyosis patterns. And then a personalized diagnostic path, imaging, labs, referrals if needed. A lot of your symptoms are related to endometriosis, but I want to make sure that we're not missing anything. And then a treatment roadmap, whether it's lifestyle changes, medical, surgical. It all depends on your symptoms and what you've tried and kind of what next steps are. So at the end of the consult, if you feel like you didn't get anything out of it, of course, we'll refund you. We want you to feel 100%, satisfied. Endometriosis is a very tricky disease, and the way that it affects your body is complex. And it's important to understand the complexities of these diseases, both the endometriosis and the adenomyosis, but also to understand next steps into a treatment program to help reverse some of the long-term sequelae and damage the endometriosis has caused, but also giving you fresh outlook and kind of a clean slate to continue to progress, whether your goal is fertility or pelvic pain or just quality of life, finding that balance. And understanding and what's going on in your body is really step one. So I enjoyed talking with you guys, for the last hour. I have a few other questions in the chat, and we'll go through those. So one person says, can I have both endometriosis and adenomyosis? And yes, I think we hit on that. So at least 30% of women with endometriosis also have adenomyosis. Women with adenomyosis, especially if we can see it on imaging, about 80% of them have endometriosis. So it's very common that they can happen together. Somebody else asked me, if you see endometriosis on the colon or the bowel, do you feel comfortable removing it? Absolutely. At least 30% of my patients have endometriosis on your colon or rectum or sigmoid colon. And it's imperative to remove all of the disease or you won't get the outcome that you deserve. Sometimes I have, colorectal surgeons come help me, but most of the time I'm able to do the endometriosis on my own. And I feel very comfortable doing that from the nerves, from the bladder, from the uterosacral ligaments, from the nerves. Really, wherever we find it, we're prepared to handle it, even the diaphragm. Next, somebody mentioned is, why has nobody mentioned this to me before? Why is this the first time I'm hearing about adenomyosis? And And I think that that's a really difficult decision. I think it's a breakdown of the medical system. I think it's a disadvantage to women's health and some of the funding that we're given. And my goal in my career is to try to change that, to try to advocate for women, talk more about endometriosis, talk more about adenomyosis, talk more about um, treatments, options. But this is a very real disease. It is not in your head, it is in your pelvis. And trying to find an individualized, personalized plan for you to get your best outcome is paramount. So thank you guys for meeting with me today. And I really, I enjoy talking with you guys. I know that it's, um, uh, a long hour, but thank you for meeting with me. I hope you learned a little bit about endometriosis and its correlation with adenomyosis. And I look forward to seeing you, in the office. Click on that link below and schedule a phone call with Cyrus to get you on my schedule, or call the office and get on the schedule. But I look forward to seeing you and getting to know more about you. Y'all have a good rest of your Wednesday. Bye bye.